Okay. 12-hour study stream. I don't think you can see my timer. Just something to... If I do this in like... Oh, okay, that's interesting. Let's see how that looks. Oh, it's because I'm... Okay. I think the stream is alright. That's fine. That's fine. Password and live streaming, my only windows open. Cool. I feel like we'll take a 5-minute break. I want to check how much resp notes there are. Not this. It's 21 conditions, so 1, 2. So we need to do someone said something about the camera. Let me see how that is. I'm not going to get 7 conditions done in 30 minutes though. That's the thing. I feel like if we take from that, it's fine. That'll take us until 4 AM. And then see what happens at 4 AM. Basically. There will be a power nap somewhere in here. So if you do change that to a 4, change that to 4, change that to 5, 6, that's 7. So we're not going to do resp, obviously. That second block we can do. Gesture. I want to just finish. And then we'll do resp and gesture questions. Obstinary. Split it like that, it should be fine. So somewhere will be a power nap, and then if we do, because we only need to go, we need to do until 12:30, so let me do. I think this plan is going to go horribly wrong. Resp and gesture and OBG and cardio questions. I think this is going to go horribly wrong, but we'll do it anyway. We'll see how far we go in. Is there a dark mode? I want everything in dark mode. Oh, this is excellent. Great. Yeah, actually I should do an overlay, shouldn't I? Just add text. Oh god, where's it gone? I don't know where the text has gone. I'm just going to delete it. Let's see how that looks. That's quite cool. That's fine. I need to do the rest breeding by 1:30. Yeah, okay. Let's see. So by 3 o'clock I have to be ready for rest questions, basically. Okay, right, well, I'll do the reading. Crazy. Okay, it's 1 o'clock. So basically, I just need to get the reading done for the rest conditions. So, bronchitis. Okay. So get the reading done. I'm gonna go pray quickly, and then take it from there. I'm gonna leave my phone on charge. Then what do I do? Yeah, I think so. I think that works. If I just... My shirt, man. That. Wicked. Okay. Is that gonna charge? Cool, phone's on charge. Other phone's here. So I'm gonna go pray. Just take this upstairs as well. Okay, alright, be back in a minute. Okay. Right, legit. Let's do it, guys. Just need to pray and then. Okay, alright. Let's get activated, bro. And then we'll get to the rest of the notes. Okay, right. Let's slide. Okay. Start reading these notes. Well, I mean, I read some upstairs, but I mean, we'll read the rest now anyway. Okay. So with bronchitis, patients present with cough, this hotspot kills my battery so quick. Minor though. Alright. Some patients may present with a low-grade fever and the wheeze, but it's a cough, sore throat, rhinorrhea. Rhinorrhea is a runny nose, I think. And that wheeze. So how do you differentiate that acute bronchitis from pneumonia? So with bronchitis they might not have the sputum, wheeze or breathlessness, but in pneumonia they do. The examination, no other focal chest signs, so no dullness to percussion, bronchial breathing, acute bronchitis other than wheeze, so there'll be more of a systemic features, maybe absent in acute bronchitis where they'll Bro, the next notification, I'm turning off my phone. and I need my phone to run the stream because I use the hotspot, for God's sake. But okay, right, lock in. Yeah, minor. Analgesia, good fluid intake. Antibiotic therapy if patients are stomachically unwell, pre-existing comorbidities. Oh, so if the CRP is between 20 and 100, so this is for acute bronchitis. Offer that delayed prescription of what? Doxycycline for bronchitis. And if the CRP is greater than 100, but that's if it's definitely bronchitis, because if it's pneumonia, apparently you do something else. Doxycycline contraindicated in the children and pregnant women. Cool. Alternatives. It's fine, should we check this out on CKS? Let me see what the ChatGPT says about the CKS. So, continue. Do I know any of these people? No. Don't. One, two. Who the heck is you? Oh wow. So crazy, I didn't even connect my contacts. Don't allow that. Minor. Three to 4 weeks. Management focused on support care, advising rest, fluid intake, blah blah blah. So acute bronchitis is usually viral. Basically, that's it. Okay, right. So I'm going to take that off. Oh god. All right. Allergic rhinitis. I think most of them are fine. Most of these conditions, like allergic rhinitis. What are you going to do? think I'm going to play some music. I need to make sure it's music that I can't get copyrighted for. Let me... No copyright music. Copyright background music. Really in the trenches right now, man. How does that? I think it's okay. No? Okay, yeah, let's just turn it off, it's fine. So with allergic rhinitis, we're going to avoid the allergens, mild to moderate, intermittent, symptoms, moderate to severe. So antihistamines, intranasal antihistamine, I didn't know that was a thing. That's a steroid. Alright, is azelestine? Azelestine. Okay, yeah. That's the only one licensed. Okay. Intranasal corticosteroids. Yeah, cool. Don't use them for a long time. The metazolines. Fine. Allergy tests. So there's a skin prick test. Right, okay, so raw skin pitch testing, contact dermatitis. So there's a difference between prick testing and pack testing. Crazy. terrifying. Okay, right, lock in. Skin patch testing, contact dermatitis. I don't even know why this is in RESP. But okay, right, go on. Okay. So cow's milk protein intolerance and allergy occurs in around 3 to 6% of all children, typically after the first 3 months of life. So basically, if it's serious, if there's like respiratory involvement, because this sounds peak, that's like not that deep in it. Get nausea's not here, is it? No, so it's like, it's not that deep on this one with the non-IgE mediated, essentially, like the way that I'm thinking of it. And so that's why they're saying you can eliminate it, you're kind of like self-treating almost here. 2 to 6 weeks, then reintroduce. And then consult a dietitian. Okay. Offer a skin prick test or blood test for specific. I want to see what the textbook says about that actually. Nutrition. Or would it be under RESP? No, is it gastro? No. Oh, is it immunology? Allergy, here we go. Signing through institution. Take its time. Food allergy, here we go. Oh, I wish there was a dark mode for this thing.
Egg allergy is mostly mild or moderate. Symptoms include perioral or facial erythema, urticaria, and angioedema, often with vomiting. Diarrhea is rare. In more severe egg allergy, asthma, and anaphylaxis occur. Egg allergy can be partial, and at presentation, the child may tolerate a low allergen dose. For example, egg is a baked ingredient, but not whole cooked egg. Most egg allergy in infants and young children resolves by or before school age. Management includes exclusion of egg from the diet and review to decide on timing and pace of gradual egg reintroduction. In the minority where disease persists, this can be severe, as an adult or teenage onset egg allergy. The measles, mumps, and rubella MMR vaccine does not contain egg protein and can safely be given. Inactivated, injected influenza vaccines that are egg-free or contain egg protein at very low levels can be given to most patients with egg allergy. Children from age 2 years with egg allergy should be vaccinated with a nasal influenza vaccine. Yellow fever vaccine contains egg, thus specialist advice is required. A desensitization protocol and incremental dose regime have been trialed and shown to be effective in a small number of patients. Cow's milk allergy. Mild to moderate cow's milk allergy causes similar symptoms.
I don't know if I could show the textbook on the stream. But anyway, so it's basically just saying if it's not that deep, if there's no like IgE mediated effect, like suggestive things, then you abstain for 2 to 6 weeks and then reintroduce. I think that makes sense. And then if it's serious, like offer a skin prick test. And bloods. Latex allergy. Latex allergy more common in children with myelomeningocele spina bifida. People who are allergic to latex are also allergic to fruits, banana, pineapple. Strawberry, okay. Pollen food allergy, just plant-based foods. Oh, that's pretty cool. Okay, right. Oh, this is boring. Penicillin allergy. Allergy to penicillin-based antibiotics common, although many patients who report an allergy. So 0.5% to 6.5% of penicillin-sensitive patients will also be allergic to cephalosporins. Patients with a history of immediate hypersensitivity to penicillin should not receive a cephalosporin. Cephalosporin is... What's an example of cephalosporin? Cyclosporin, right? Oh, that's GPT. Cyclosporin. Oh no, I'm crazy. So no Kef. So basically none of the Kefs. Bro, that's so embarrassing. So what is cyclosporin? Icavis. I'm thinking of Icavis, innit? Bro, my bad, man. Look. I'm not crazy. Look, Icavis cyclosporin. I was thinking of that. I don't know why. Sorry. So embarrassing. Okay, right. Anyway. So phenoxybenzyl flute, clox, ampicillin, amoxicillin, cofluampicil, ampicillin, fluvoxamine. Tazocin, Timentin. That's fine. Venom allergy. So, advise the patients or a medical alert device. Okay, interesting. So, medical alert devices are basically like these wristbands or necklaces that say like this person's allergic to X and Y. Yeah. Yeah, okay. Bro, I'm gonna go crazy. Okay, we're just gonna let Speechify read it out. So I think I'm gonna do how I did Room and Ortho. Mesothelioma is fine. I have no idea what I'm genuinely looking at, but okay. So we're going to do asthma. So Wait, what? That has not copied over properly. Spin it off. Actually, what we can do is. Com. Bro, I need to read these guidelines, man. Com. Can't even see that. Probably fine. Stepping down treatment. Right, okay, so this is everything on asthma. So now if we get Speechify to start reading, will it read is the question.
Asthma. Acute asthma is nearly always seen in patients who've got a history of asthma. Worsening dyspnoea,
Acute asthma is nearly always seen in patients who've got a history of asthma. Is that real? Incredible. Okay. I'm not gonna say anything.
Acute asthma is nearly always seen in patients who've got a history of asthma. Wheeze and cough. Cough that is not responding to salbutamol may be triggered by a respiratory tract infection. Patients with acute severe asthma are stratified into moderate, severe, or life-threatening. Moderate, it's ever life-threatening. PFR 50 to 75, best or predicted speech, normal RR, less than 25. Mid-pulse, less than 110. BPMPEIR, 33 to 50%. Best or predicted can't complete sentence SRR, greater than 25. Min-pulse greater than 110. BPMPEIR, less than 33%. Best or predicted oxygen, stats less than 92% on the chest, cyanosis or feeble respiratory effort bradycardia, dysrhythmia or hypotension exhaustion, confusion or coma. In an acute asthma attack indicates exhaustion and should therefore be classified as life-threatening. The British Thoracic Society, yes, classification of acute asthma is moderate, severe, or life-threatening categories. Moderate, it's ever life-threatening. TEPR 50 to 75. Best or predicted speech normal R less than 25. Min-pulse less than 110 BPM. 33 to 50%. Best or predicted can't complete sentences are greater than 25. Min-pulse greater than 100. And 10 BPM AVR less than 33% best or predicted oxygen. oxygen, stats less than 92% normal, PC024. 0.6 to 6 kPa silent chest, cyanosis or feeble respiratory effort bradycardia, dysrhythmia or hypotension exhaustion, confusion or coma. Note that a patient having any one of the life-threatening features should be treated as having a life-threatening attack. It is also recognized characterized by a raised PC0 and or requiring mechanical ventilation with raised inflation pressures. The BTS guidelines recommend arterial blood gases for patients with oxygen stats less than 92%. A chest x-ray is not routinely recommended, unless all patients with life-threatening should be admitted in hospital. Patients with features of severe acute asthma should also be admitted if they fail to respond to initial treatment. Other admission criteria include a previous near-fatal asthma attack, pregnancy, and attack occurring despite already using oral corticosteroid in presentation at night. If patients are hypoxemic, it is important to start them on supplemental oxygen therapy. If patients are acutely unwell, they should be started on 15% L of supplemental via a non-rebreathed mask, which can then be titrated down to a flow rate where they are able to maintain a SPO 90% forward to 98%. Bronchodilation with short-acting beta, agonist SABA, high-dose inhaled SABA, for example, salbutamol, debutaline. In patients without features of life-threatening or near-fatal asthma, this can be given by a standard pressurized metered-dose inhaler PMDI or by an oxygen-driven nebulizer. In patients with features of a life-threatening exacerbation of asthma, nebulized SABA is recommended. All patients should be given 40 to 50 mL of prednisolone orally PO daily, which should be continued for at least 5 days until the patient recovers from the attack. During this time, patients should continue their normal medication routine, including inhaled corticosteroids, ipratropium bromide in patients with severe or life-threatening asthma, or in patients who have not responded to beta, agonist and corticosteroid treatment, nebulized ipratropium bromide, a short-acting muscarinic antagonist. The BTS notes that the evidence base is mixed for this treatment that is now commonly given for severe life-threatening asthma. IV aminophyllene may be considered following consultation with senior medical staff. Patients who fail to respond require senior critical care support and should be treated in an appropriate ITU, HDU setting. Treatment options include extracorporeal membrane oxygenation ECMO, been stable on the discharge medication that is no nebulizers or oxygen for 12 to 24 hours. The 2016 BTS sign guidelines suggest the following criteria are used to assess the severity of asthma in children. Children with severe or life-threatening asthma should be transferred immediately to hospital. Children between 2 and 5 years of age. Moderate attack, severe attack, life-threatening attack. SVO2 greater than 92% of clinical features of severe asthma. SVO2 less than 92% due breathless to talk or feet heart rate greater than 140, min respiratory rate greater than 40%, min use of accessory neck muscle SPO less than 90, 2% insolent chest 4 respiratory effort agitation altered consciousness cyanosis. Children greater than 5 years of age. Attempt to measure PEF in all children age greater than 5 years. Moderate attack, severe attack, life-threatening attack. CO2 greater than 92% BEF, greater than 50% BEF, or predicted no clinical features, all severe asthma. SVO2 less than 90, 2% BEF, 33 to 50% best, or predicted can't complete sentences in one breath, or 2 breathless to talk, or feet heart rate greater than 125, min respiratory rate greater than 30%, min use of accessory neck muscle SPO less than 92% BEF, less than 33% best, or predicted ceiling chest 4 respiratory effort altered consciousness cyanosis. For children with mild to moderate acute asthma, give a beta 2 agonist via spacer. For a child less than 3 years, use a close-fitting mask. Give 1 puff every 30 to 60 seconds up to a maximum of 10 puffs. If symptoms are not controlled, repeat beta 2 agonist and refer to hospital. Should be given to all children with an asthma exacerbation. Usual prednisolone dose in 2024 Quarterbase, the British Thoracic Society and SIGN produced joint guidelines on the management of asthma following many years of conflicting guidelines. The new guidelines represent a major step change in the management of asthma, is both diagnosed and treated, investigating suspected asthma in adults. Measure the eosinophil count or fractional nitric oxide, FeNO. Diagnose asthma without further investigation if asthma is not confirmed by the eosinophil count or FeNO. Measure bronchodilator reversibility BDR with spirometry. The FF increase is greater than or equal to 12% and 200 milliliters or more from the pre-bronchodilator measurement, or the FEV increase is greater than or equal to 10% of the predicted normal FEV. If spirometry is not available or it is delayed, measure peak expiratory flow PEF twice daily for 2 weeks. PEF variability expressed as amplitude percentage mean is greater than or equal to 20%. If asthma is not confirmed by eosinophil count, FeNO, BDR, or PEF variability, but still suspected on clinical grounds, refer for consideration of a bronchial challenge test. Diagnose asthma if bronchial hyperresponsiveness is present. Investigating suspected asthma in children aged 5 to 16. Measure the fractional nitric oxide FeNO. If the FeNO level is not raised or if FeNO testing is not available, measure bronchodilator reversibility BDR with spirometry. The FEV increase is greater than or equal to 12% from the pre-bronchodilator measurement, or the FEV increase is greater than or equal to 10% of the predicted normal FEV. If spirometry is not available or it is delayed, measure peak expiratory flow PF twice daily for 2 weeks. PF variability, expressed as amplitude percentage mean, is greater than or equal to 20%. If asthma is not confirmed by FeNO, BDR, or PF variability but still suspected on clinical grounds, perform skin prick testing to house dust mite or measure total IgE level and blood eosinophil count. Exclude asthma if there is no evidence of sensitization to house dust mite on skin prick testing or if the total serum EGA is not raised. Diagnose asthma if there is evidence of sensitization or a raised total IgE level and the eosinophil count is greater than 0.5 times 10 IL. If there is still doubt about the diagnosis, refer to a pediatric specialist for a second opinion, including consideration of a bronchial challenge test. Investigating suspected asthma in children under 5. The guidelines acknowledge the difficulty of performing tests in such young children. They suggest treating with inhaled corticosteroids as per the management guidelines with regular review. If they still have symptoms at age 5, then attempt objective tests. Refer to a specialist respiratory pediatrician any preschool child with an admission to hospital or 2 or more admissions to an emergency department with wheeze in a 12-month period. Notes on the investigations are specifically involved in type 2 inflammation, a key immunological pathway in many asthma phenotypes, making them a targeted marker for disease activity. Unlike other white blood cells, eosinophils play a direct role in airway inflammation by releasing granules containing cytotoxic proteins like eosinophil peroxidase and major basic protein, which damage epithelial cells and perpetuate inflammation. Additionally, eosinophils are activated by interleukin-5, IL-5, and other cytokines in the type 2 pathway, distinguishing them from neutrophils or lymphocytes, which are more associated with other immune responses. IL-5 is an important target in new monoclonal antibody treatments such as mepolizumab. reflects the level of nitric oxide produced by airway epithelial cells in response to eosinophilic inflammation, a hallmark of asthma. It is measured non-invasively by having the patient exhale steadily into a handheld device, which analyzes nitric oxide concentration in parts per billion ppb. Bronchodilator reversibility (BDR) testing with spirometry evaluates the degree of airflow limitation that improves after administration of the bronchodilator, a key diagnostic feature of asthma. In asthma, airway obstruction results primarily from reversible bronchial smooth muscle constriction and airway inflammation, which can respond to bronchodilators by relaxing the smooth muscle and reducing resistance. Measuring effort. Before and after bronchodilator administration demonstrates its reversibility, with an increase of greater than or equal to 12% and greater than or equal to 200 ml, indicating significant improvement. This reversibility distinguishes asthma from fixed airway obstruction seen in conditions like COPD, where airflow limitation is less responsive. Reflects diurnal changes in airway caliber, a hallmark of asthma, due to underlying circadian rhythms in airway inflammation and bronchial smooth muscle tone. Airway narrowing tends to worsen at night and in the early morning due to increased parasympathetic activity, nocturnal histamine release, and lower circulating cortisol levels, all of which contribute to heightened airway hyperresponsiveness. This diurnal pattern, with a greater than 20% variation in PEP between morning and evening values, supports the diagnosis of asthma and highlights its dynamic, reversible nature. Plays a central role in allergic asthma by mediating hypersensitivity reactions through binding to high-affinity IgE receptors on mast cells and basophils. Upon allergen exposure, cross-linking of bound IgE triggers the release of inflammatory mediators like histamine and leukotrienes, leading to airway inflammation, bronchoconstriction, and asthma symptoms. Measuring serum IgE levels helps identify atopic asthma phenotypes, predict responsiveness to anti-IgE therapies such as omalizumab, and guide management strategies in patients with allergic triggers. For house dust mite is performed because it is measured non-invasively by having the patient exhale steadily into a handheld device, which analyzes nitric oxide concentration in parts per billion ppb. Bronchodilator reversibility (BDR) testing with spirometry evaluates the degree of airflow limitation that improves after administration of the bronchodilator, a key diagnostic feature of asthma. In asthma, airway obstruction results primarily from reversible bronchial smooth muscle constriction and airway inflammation, which can respond to bronchodilators by relaxing the smooth muscle and reducing resistance. Measuring effort. Before and after bronchodilator administration demonstrates its reversibility, with an increase of greater than or equal to 12% and greater than or equal to 200 ml, indicating significant improvement. This reversibility distinguishes asthma from fixed airway obstruction seen in conditions like COPD, where airflow limitation is less responsive. Reflects diurnal changes in airway caliber, a hallmark of asthma, due to underlying circadian rhythms in airway inflammation and bronchial smooth muscle tone. Airway narrowing tends to worsen at night and in the early morning due to increased parasympathetic activity, nocturnal histamine release, and lower circulating cortisol levels, all of which contribute to heightened airway hyperresponsiveness. This diurnal pattern, with a greater than 20% variation in PEP between morning and evening values, supports the diagnosis of asthma and highlights its dynamic, reversible nature. Plays a central role in allergic asthma by mediating hypersensitivity reactions through binding to high-affinity IgE receptors on mast cells and basophils. Upon allergen exposure, cross-linking of bound IgE triggers the release of inflammatory mediators like histamine and leukotrienes, leading to airway inflammation, bronchoconstriction, and asthma symptoms. Measuring serum IgE levels help identify atopic asthma phenotypes, predict responsiveness to anti-IgE therapies such as omalizumab, and guide management strategies in patients with allergic triggers. For house dust mite is performed because it is a common and potent trigger for asthma, particularly in atopic individuals. House dust mite allergens, found in household dust, are inhaled and can lead to chronic airway inflammation, increased bronchial hyperresponsiveness, and exacerbations in susceptible individuals. Identifying house dust mite sensitivity allows targeted interventions, such as allergen avoidance measures, to improve asthma control and reduce symptom burden. Assesses airway hyperresponsiveness, a characteristic feature of asthma, by measuring the airway's response to a provocative agent such as methicillin or histamine. In asthma, heightened bronchial smooth muscle reactivity and inflammation lead to excessive narrowing of the airways when exposed to these agents, resulting in a significant decline in PEP. In 2024 quarterbase, the British Thoracic Society and SIGN produced joint guidelines on the management of asthma following many years of conflicting guidelines. The new guidelines represent a major step change in the management of asthma, is both diagnosed and treated. For many years, patients with asthma were started on a short-acting beta-2 agonist SABA inhaler before stepping up to a regular inhaled corticosteroid with a SABA as required. The new guidelines now advocate the use of combined inhalers, ICS plus long-acting beta-2 agonists, as reliever therapy or regular, depending on severity of asthma. Given the prevalence of asthma, it is likely that doctors will have to deal with patients on conventional asthma treatments for many years to come. The joint guidelines therefore include guidance on how to manage these patients if their current treatment is controlling their symptoms sufficiently. Management of adult patients aged children aged greater than or equal to 12 years with newly diagnosed asthma. A low-dose inhaled corticosteroid, ICS, formoterol combination inhaler to be taken as needed for symptom relief. This is termed anti-inflammatory reliever air therapy. If the patient presents highly symptomatic, for example, regular nocturnal waking, or with a severe exacerbation, start treatment with low-dose MART, maintenance and reliever therapy see below. Treat the acute symptoms as appropriate. For example, a course of oral corticosteroids may be indicated. MART describes using an inhaled corticosteroid ICS, formoterol combination inhaler for daily maintenance therapy and the relief of symptoms as needed, that is regularly and as required. Check the fractional exhaled nitric oxide phenol level available in the blood eosinophil count. Nice. If either of these is raised, refer to a specialist in asthma. If neither FeNO nor eosinophil count is raised, consider a trial of either a leukotriene receptor antagonist LTRA or a long-acting muscarinic receptor antagonist LAMA, used in addition to moderate dose MART. If control has not improved, stop the LTRA or LAMA, and start a trial of the alternative medicine, LTRA or LAMA. Refer people to a specialist in asthma care when asthma is not controlled despite treatment with moderate dose MART, and trials of an LTRA and a LAMA. Transferring people aged 12 and over from other treatment pathways. There will be many people whose asthma was managed according to the previous guidelines that present with uncontrolled asthmatic symptoms. The guidelines give advice on how these people should be switched. Existing asthma treatment, new asthma treatment. SABA, as required, only low-dose ICS formoterol combination inhaler used as needed air therapy. SABA, as required, plus regular low-dose ICSABA, as required, plus regular low-dose ICs. Lavasaba, as required, plus regular low-dose ICS plus. Ultrasaba, as required, plus regular low-dose ICs. LABA, plus ultra-regular low-dose
I hope you guys understand
formoterol
that.
combination inhaler, MART therapy. SABA as required, plus regular moderate dose ICSABA as required, plus regular moderate dose IP, LABA-SABA as required, plus regular moderate dose ICS, plus LTRA or LAMA-SABA as required, plus regular moderate dose ICs LABA, plus LTRA or non-regular moderate dose MART therapy. Treatment regime containing a high-dose Ixofer to a respiratory specialist. In 2024 Quarterbase, the British Thoracic Society and SIGN produced joint guidelines on the management of asthma following many years of conflicting guidelines. The new guidelines represent a major step change in the management of asthma, is both diagnosed and treated. For many years, patients with asthma were started on a short-acting beta-2 agonist SABA inhaler before stepping up to a regular inhaled corticosteroid with a SABA as required. The new guidelines now advocate the use of combined inhalers, ICS plus long-acting beta-2 agonist, as reliever therapy or regularly, depending on severity of asthma. Given the prevalence of asthma, it is likely that doctors will have to deal with patients on conventional asthma treatments for many years to come. The joint guidelines therefore include guidance on how to manage these patients if their current treatment is controlling their symptoms sufficiently. One of the key concepts is the use of maintenance and reliever therapy, MART. This describes using an inhaled corticosteroid, ICS, formoterol combination inhaler for daily maintenance therapy and the relief of symptoms as needed. That is the same combined inhaler regularly and as required. Management children aged 5 to 11. Twice daily pediatric low-dose inhaled corticosteroid, ICS, plus short-acting beta-2 agonist SABA as needed. If this doesn't control the child's asthma, then a decision needs to be made about whether the child is suited to a MART regime or not. This determines whether the child is then managed down a MART or conventional pathway. Symptoms not controlled on first step in pediatric low-dose Martin SABA as needed SABA. As needed symptoms still not controlled in pediatric moderate dose Martin SABA as needed. Symptoms not controlled on first step in natoleukotriene receptor antagonist LTRA to twice daily pediatric low-dose ICS plus SABA as needed. Give the LTRA for a trial period of 8 to 12 weeks, then stop it if it is ineffective symptoms still not controlled. And switch to a twice daily pediatric low-dose ICS LABA long-acting beta-2 agonist. Combination inhaler plus SABA as needed. This can be with or without LTRA depending on the results of the previous trial symptoms still not controlled. And switch to a twice daily pediatric moderate dose ICS LABA long-acting beta-2 agonist combination inhaler plus SABA as needed. This can be with or without LTRA depending on the results of the previous trial. If children's symptoms are still not controlled despite the above, then a referral should be made to a respiratory specialist. Management in children under 5, 8 to 12 week trial of twice daily pediatric low-dose ICS as maintenance therapy plus SABA as required. Consider stopping ICS and SABA treatment after 8 to 12 weeks if symptoms are resolved. Review the symptoms after a further 3 months. The British Thoracic Society BTS guidelines recommend that we should consider stepping down treatment every 3 months or so. The guidelines don't advocate a strict move from say step 3 to step 2, but advise us to take into account duration of treatment, side effects, and patient preference. When reducing the dose of inhaled steroids, the BTS advise us to do this by 25 to 50% at a time. Clearly, patients with stable asthma may only have a formal review on an annual basis, but it is likely that if a patient has recently had an escalation of asthma treatment, they would be reviewed on a more frequent basis.
Yep, you'd hope so. Okay, right. Fine. I feel actually quite a bit more confident with asthma now. It's quite good. Right, okay. So we managed to do 4. Let's do some rest questions. Oh god. $67 RA 9 years X ratio. This is way darker than usual, I think. I'm not even looking at the X-ray for God's sake. Right, okay. Bro, what is that? There's obviously that big circle there, but I don't think it's emphysema. Is it a lung abscess, bronchiolitis? That one? I thought it was a lung abscess. Okay, right, 50-year-old man, shortness of breath, 1 week, pleural effusion, it's just X-rays. This type of pleural effusion. I don't know, lactate dehydrogenases, 346, more than 200. Protein, is it the renal failure? No. Exudated pleural effusion, peak. something to do with the protein. I think I'm going to call it a night. You know, we're pushing the social media campaign. Okay, right. Let's get like a few more questions in. I think we'll push it to like 2 hours. Been live for an hour and 47 minutes, I think. Gets 2 hours. Call it a night. 31-year-old lady, Gravida 1, Para 0. I don't even know what that means. "24-year-old male presents to your GP surgery with 2-week history of widespread swelling and painful joints. Fix the majority of his joints, both large and small, so that's only one deal. No recent sexual exposure. Serum ACE are twice the upper level of normal. Anti-CCP is negative. What's anti-CCP for? I think that's RA, so it's not RA. It's got in the wrist. I've no idea. Yep. I had no idea. Should have read sarcoidosis. It's fine. 66-year-old man attends the ED with a productive cough and increased lethargy. He has a history of hypertension for which takes 5 mg amlodipine. He's confused and needs several prompts to follow commands. Alright, okay. So he's got a fever. His heart rate's a bit high. He's fine blood pressure wise. He's breathing quite fast. And his stats are dropping, okay. Don't know what that is. I don't think it's not a collapse, is it? It's the right middle lobe collapse. Alright, middle lobe pneumonia. I think it's that one. Yeah, brilliant. "72-year-old male presents to his GP with progressive dyspnea, chronic cough, and a wheeze. 60-pack year smoking history. Possible stripped A to P, and he takes a Saba currently. Spirometry shows a FEV1 of 55% and a FEV1 ratio to 49%. Diurnal variation reading. Next. Oh god, he's 72. So basically, I think it's pointed towards asthma for him, but then, oh, I wish it said something about reversibility. So basically, it's pointing towards asthma, but you have to apply your knowledge here. I feel like I should know this. Salmeterol. I don't think you're going to give it LTRA. So I think that's can go in the window. Go out the bin. I don't think you're going to give any LTRA. Oh, actually, you might, because he's already on a Saba. He already takes a Saba. He's got past medical. Okay, so it is asthma. So he's got the Saba. Now we're going to give beclomethasone, salmeterol as the MART. Yeah. Oh, wicked. Oh, that's excellent. Well done, kiddo. Oh, that's really, really happy you got a question right. Alright, last question. 68 man, COPD, COPD, ED, SOB, left sided chest pain. So that was that. Oh yeah, it's the 2 centimetre thing, for God's sake. Oh, and he's short of breath as well, so. Okay. Pro what? Okay, just 5 more minutes, right? Okay, we'll do 5 more minutes. 16-year-old boy is brought into the ED by ambulance. Whilst competing in a sports event, he started struggling to breathe and could not catch breath despite using his SAVA. So 16... He's having an asthma attack, basically. Cannot complete full sentences. Widespread wheeze. Tacky. This is more about... You can't complete full sentences, so I think it's life-threatening. Yeah, cool. Oh no, I think it's because of the PCO2 apparently. Last question, 34, still worker. I think it's patch testing. It's patch testing on this one. Oh no, no it's not apparently. Okay, one more question. 64-year-old patient presents a GP worsening chronic cough. So 64 patient GP chronic cough last few days. Blood tinged sputum. So he's got bronchiectasis, so it's probably Haemophilus influenzae. Yeah, excellent. Well done. Okay, right. Let's go one more. Okay, we should get this. If we don't get this, we're going to have trouble. 16-year-old patient with CF. Oh god, okay. ABPA, bronchopulmonary aspergillosis. What do we give for aspergillosis? We don't want to give pred. Don't want to give that. Aspergillosis. I thought that was. Did you give it itraconazole? Nope. Pred. Bruh. Tuberous sclerosis. Sounds fungal. Alright, last one. No, not this. Fine, we'll do this one. 13-year-old girl presents with severe nausea, prolonged vomiting, abdomen pain. Preceding few months, she suffered from fatigue, weight loss, polydipsia, polyuria. She's got glucose and ketones in her urine. ABG shows. Where's the ABG levels? Oh, right, here we go. So, the pH is acidic, so it's an acidosis. Bicarbonate is supposed to be between 22 and 28, which is not. PCO2 is normal, and the PO2 is 10 to 14, so that's also normal. PCO2 is normal. She's in a metabolic acidosis. Cool. with that, I think I'm gonna call it a day for today's stream. Make sure you tune in for tomorrow's. Cool. Thanks guys. Have a good night.